Hi, my name is Sarah Zagroba. I'm one of the chief residents at Kendall Regional, and this is Dr. Golden, Antoinette, and we're both going to be introducing you to simulation today.
Simulation is an important of medical education for a variety of reasons. Simulation helps us decrease the amount of adverse outcomes when it comes to our patients, meaning we make our patients safer. Simulation started with aviation. Airplane pilots and aviation in general wanted safer flights. They developed a lot of checklists and they constantly ran through simulations to make sure to decrease the amount of mistakes that they made during flights. In medicine, we use simulation for the same reason. We want to decrease the amount of medical errors that occur. We do this in simulation for two main medical cases. One, for high-risk cases we see very frequently. This includes cardiac arrests, STEMIs, strokes, sepsis, and respiratory failure. But we also use it for high-risk, rare events, things like thyroid storm, that we want to make sure that we know how to capture those patients when we see them in real life. For medical simulation, we do this here at Kendall in four main ways. One, we have conferences 4 times a year where the whole conference day is simulation. Second, we have asynchronous learning. This is where the last hour of conference might be small groups for EKG, reading CTs, and a simulation case. We also have Sim Wars once a year against Aventura, and we have a large disaster drill once each year. And finally, the last way that we provide simulation education is with a simulation track. Sarah is one of our simulation track residents this year. Sarah, do you want to describe the simulation track we have?
Yep. This year I decided to do the simulation track because I wanted to improve my simulation skills as well as learn more about unique cases and really get to know them thoroughly. I also wanted to work on academics. So every month I work on a case. Typically we do them in the simulation center for the residents. So we start by designing a case from start to finish, and then we run through it and then actually perform it for the residents. It's great to see how each group goes through it individually and then see how I can improve as well as how I can improve my teaching skills for these residents.
During simulations, you want to assign roles. In each of your groups, there's anywhere between 3 and 5 medical students. Before the simulation case starts, you want to reach out to the other medical students and assign roles. One role is a leader. That person will be directing the case. The next person should be doing physical exams. That person is talking to the patient and doing a physical exam, asking for tenderness, and assessing any findings. The third person should be doing the airway. They might be assessing A, Bs, and doing any sort of intervention like intubation during the case. Finally, a fourth person might talk to family members, follow up any labs or any orders with the nurse. A fifth player of the team is going to be your nurse. You'll have 2 nurses in your simulation case. You'll have Sarah and myself, Antoinette. If you forget our names, don't worry. You can say, "Nurse, can you please give me this?" And we'll make sure to provide you with the information or give the patient that medication.
So when you get to simulation lab and you evaluate your patient, the first 3 things that you want to evaluate for are A, airway, B, breathing, and C, circulation. So in terms of evaluating for a patient's airway, you usually want to take a look at the patient and ask them their name. "Hi, miss, what's your name?"
My name's Antoinette. How are you?
"I'm good." So by a patient giving a verbal response, their airway is patent. If they're not, then you would have to think about definitive airway, which we'll talk about in a sec. The next thing that you would want to assess for is breathing, B. So breathing is by listening to bilateral breath sounds, meaning you're going to listen to both the right and the left lung. If you hear breath sounds bilaterally, breathing is intact. If not, you'd want to take a look at their oxygen level and make sure they're having an oxygen level close to 100. If it is low, you'd want to consider giving them supplemental oxygen, which we have over here. Over here we have some options, this being a nasal cannula to give them some extra oxygen. You want to think about a oropharyngeal airway just to help with opening the airway. You can consider a non-rebreather mask, suctioning them if there's anything in their mouth, and then we'll talk about definitive airway in terms of a bougie later on. Now we'll go back to the patient and we'll move on to the cardiac monitor for C.
Next, we're going to be assessing circulation. So A, B, see. So the first thing you can do to look for circulation in this patient is ask, what does their skin color look like? And you might hear pale, they have good skin color, they're diaphoretic, or they look dry, dehydrated. The next thing you can do is ask for a pulse. You can check a radial pulse. You could check a femoral pulse. On this mannequin, the femoral pulse is here. If you press, I could feel the pulse right now. If you ever have any questions, we will tell you exactly what pulse you will feel, what skin color they have. And the final thing you can look for is cap refill. So you'd press the patient and ask for how long the cap refill is, and we will let you know whether it's brisk, less than 2 seconds, 3 seconds, or 4 seconds. Anything more than 3 would be concerning that their circulation may not be intact. Here we have the monitor. The monitor, you will find the vital signs. When a patient comes in, if you ask to place them on a cardiac monitor, you will see the EKG here on the top line. The next line will have the oxygen saturation. Here you'll see the end-tidal CO2. The pulse rate will also be here, as well as the respiratory rate. And finally, you'll see the blood pressure in the left bottom hand side. Next, we'll talk about some more equipment we have here in the simulation lab. During your case, if you'd like to order anything for your patient for their airway, breathing, or circulation, some of it might be simple, like placing them on a nasal cannula or a non-rebreather. You can also ask to place them on a BiPAP or a CPAP if necessary. If a patient needs an intubation, we have some more air equipment behind us. You might choose to ask to BVM the patient while planning and preparing for your intubation. Here we have the intubation equipment. You can specify whether you want a Miller blade or a Mac, and we have all levels of both. You can specify which ET tube you would like. Typically we do a 7, 7.5, or an 8 for an adult patient. You always want to attach the ET tube to a syringe. Here we have more OPAs. You can also ask for an oropharyngeal airway. If a patient is difficult to intubate, we could use an LMA. And finally, if the patient does not have a pulse and you plan to perform CPR, you want to request that we put pads on the patient. The pads, when opened, you'll want to put one on the front and one on the side of the chest, like so.
So I walk into the room and I see my patient. I ask, what do I see, hear, and smell?
You see a 77-year-old gentleman sitting up in bed.
I see a 77-year-old gentleman sitting up in bed. Then I assess for his airway and I say, sir, what's your name? What's going on?
Hi, my name's John.
Okay, so he answers, his name is John, his airway is patent. Then I'm going to assess his breathing status. I look at him, do I see him breathing any respiratory distress?
He's breathing comfortably. He does not appear in any distress.
I'm going to listen to bilateral breath sounds at this point in time. I listen to both the right and the left side. Do I hear breath sounds bilaterally?
You hear breath sounds bilaterally, and in this patient, the mannequin actually breathes on its own.
At this next point, the patient's breathing on his own, and I hear bilateral breath sounds. I'm going to assess for circulation. I'm going to ask if the nurse can place the patient on the monitor, and we could check the O2 status. So here, the nurse placed the patient on the monitor. He has a blood pressure cuff on, he has his pulse ox on, and now I'm looking at the monitor. I'm also feeling for a radial pulse.
You feel a radial pulse. It appears to be 2+.
So I feel a radial pulse and it's 2+. I'm looking at the monitor. His heart rate's around 88. His O2 stat, which is yellow, is 98%. And he has a blood pressure of 120/80. So I would say circulation is intact. At this next point, I would want to establish an IV as well as assess the patient for what is going on today. Sir, can you tell me what's going on?
Yeah, I'm really not feeling well today.
So the patient just says he's not feeling well today. Can you tell me a little more about that?
The IV is established.
The nurse establishes an IV.
So the patient tells you that he started having chest pain about an hour before he came in today.
Okay, so the patient's telling me that he is having chest pain that started an hour prior to arrival in the ER. Next point, I want to consider putting the patient on a cardiac monitor, which we see right there, up on the top, on the green, on the screen. And I want to administer oxygen as needed. Right now, his oxygen saturation is 98%, so he doesn't need any extra oxygen, which would be over here, the nasal cannula, the non-rebreather, and I have a definitive airway over there. However, if the patient's oxygen saturation was not great and it was actually low, as in 90%, the yellow on the screen, I would want to consider giving the patient extra oxygen. So we would go over here to look at other possible options. Because he has a lower oxygen, I would want to start at my most basic, which is the nasal cannula. It can go up from 1 to 15 liters, and usually you stop around 6 before switching to another method. So initially, I would want to say, nurse, can I place him on nasal cannula?
Yes, and I place the patient on nasal cannula.
I would be reassessing, and his oxygen now is 100% with nasal cannula. So he is doing well with the extra oxygen.
One of the concepts we teach in simulation is something called link phrase. Meaning anytime you see a patient with a specific finding, you always want to follow it with one action. So for instance, when assessing someone's circulation, say when you talk to them, you go, "Hi John, how are you doing today?" And there's no response. You want to verbalize, the patient's unresponsive, somebody check a pulse. So in this case, "Hey John, how are you feeling today?" There's no response. The patient's unresponsive. "Sarah, can you check a pulse?"
There is no carotid pulse, Dr. Golden.
The patient doesn't have a pulse. Let's start CPR. We want to lower the bed all of the way. You want to start compressions at a rate between 100 and 120. She's compressing with full depth and full recoil. She's leaning and pivoting from her hips, and her arms are straight. This allows for the most force with the least amount of exertion. CPR is very tiresome. You always want to switch who is doing compressions every 2 minutes. During CPR, as the person is doing CPR, we want to place those cardiac pads that we talked about earlier. We're going to place those pads on the right side of the chest and the left axillary area. You can also place it on front and back, especially in our pediatric patients. In this patient, you'd want to give epinephrine every 3 to 5 minutes. You can ask the nurse to give 1 milligram of epinephrine. When someone has a cardiac arrest, we put them into 2 different categories. Whether they have asystole, meaning no rhythm on the monitor, PEA, which is pulseless electrical activity. This would look like a normal sinus rhythm we have on the monitor, but the patient has no pulse. The second category is ventricular tachycardia or ventricular fibrillation. The reason we put these into 2 categories is because there's 2 different treatment algorithms. As you may recall from ACLS, if someone does not have a pulse and they are at asystole or PEA, we address H's and T's. If someone does not have a pulse and they're in ventricular fibrillation or ventricular tachycardia, we treat them with mainly 3 things. Good compressions, we use the defibrillator monitor to defibrillate them every 2 minutes, and we give epinephrine every 3 to 5 minutes. We keep it very simple in that category. Before, we showed sinus tachycardia on the monitor. Here, we have ventricular tachycardia. It's a wide rhythm that is polymorphic, meaning it's different shapes along the monitor. Here we have VFib. VFib is more coarse, isn't as well defined, and doesn't have that mountain-like appearance. Both of these, ventricular tachycardia and ventricular fibrillation, we use the defibrillator. We would charge to 200 joules and deliver those joules to the patient in hopes that we can cardiovert them to a new rhythm. Here we have asystole. This will look like a flat line on the monitor. You always want to ensure that the electrical monitor is on the patient during asystole. You would confirm by checking the pulse and confirming that the patient does not have a pulse. Following a cardiac arrest, if a person says that they have found a pulse, you want to do 2 things. You want to say, "We have a pulse. Let's get a new set of vital signs, including a blood pressure and an EKG." Those things are very important because it helps us give fluids to a patient, start pressors, or activate the cath lab if a person's having a STEMI. During simulation, we like to use something called closed loop communication. This is to decrease the amount of potential errors. An example of this is, say I'm going around the corner and I'm going to grab a cup of coffee. Hi Sarah, I'm going to go to the cafe. Would you like anything?
Oh yes, can you get me a colada with sugar?
Okay, I'll grab you a colada with sugar. Another example of this might be with an actual patient medication. So if I'm the nurse and Sarah's the resident and she would like me to give a patient a medication, the following might happen.
Hi, Dr. Golden, or the nurse. Can you administer 10 milligrams of labetalol for the patient?
Yes, I'm going to give 10 milligrams of labetalol to the patient.
Yes, thank you.
Another way to communicate is checkbacks. So let's use a medical example for how Sarah might order a medication and I would clarify as her nurse.
Hi, nurse, can you give me 10 milligrams of labetalol?
Yes, would you like 10 milligrams of labetalol IV?
Yes, 10 milligrams labetalol IV.
Okay, 10 milligrams of labetalol IV administered. During your case and you feel like you're stuck, it's always okay to phone a friend or consult your attending. If during the case you feel like you need that help, you can always say, I'd like to phone my attending and ask for additional help on where we should go next. And we'd be happy to sort of guide you or point you in the right direction.